a locking, and the locking that we'll use below will be a sort of a combination of a ligamentous locking into flexion with a little rotation. So there's going to be some coupling below. And then we're going to use a coupling above into flexion. So let's just see what kind of combination goes to check whether it's a congruent or a non-congruent lock that is being done by everybody. Before anybody knew anything about congruent and non-congruent lock. Is it a physiological or a non-physiological position? That's what we used to call it. Okay, so I'm going to put one leg down, which is the sort of classical position. I shall take the other leg up like this, and what I have to do when I'm setting this up, as we know, but I'll just go over this again with you, is to make sure that the leg is in its manipulating position. It's no good kind of testing it out here and then putting it down because you've taken the movement too high. And on this course I wouldn't need to say that, so apologies for that. As I come up here, I just take up to the joint that I wish to move, and I back off a little bit, because that joint has to be in its neutral position. And it's very easy to go through it and back off from below upwards, whereas when you're doing the rotation from above downwards, you shouldn't get to the joint. Otherwise you've got to take it all out and reset the thing. So I'll say that that is in the neutral position from below upwards. And now what I'm going to do is to keep her in the sideline position, take her arm here and do the rotation down to inflection, as you notice, because I was pulling her forward like this, and I'm just rotating down to, but not including the dysfunctional joint. That's still in its neutral position. So what have we got? I've rotated her to the left-hand side because she's laying on her right-hand side, so I've rotated her to the left-hand side, which means all the facets on the top side have gapped open, and all of the facets on the low side have become the axis of rotation, if you like. And as we've focused it down by the little diagram that we saw from Kirkcaldy-Willis, it's like taking a long piece of paper and sort of twisting it down here and twisting it up here, and we have a twist point. And the twist point where the two forces come together, at this moment that point is not, we've not taken up the extremes of that, it's still in its local neutral position, but we've gone up to that, we've come down to that, and that leaves us free then to build up the barrier at the last minute at this joint. Now have a look at this. It's in flexion. What is the side flexion that's gone on there in that upper group? Right. It's in right side flexion. And it's in right side flexion with left rotation in flexion. What kind of locking would that be? Incongruent locking. So that would be the non-physiological position.
The tight position.
The tight position, yes. So I've got all of this, and that's the classical position. Now then, the joint that I want to do is still neutral. And now I've got a lot of possibilities. What am I going to do with it? Am I going to distract it? Am I going to rotate it? Am I going to side flex it? Am I going to extend it? Well, in the classical position, it will be rotated. And in the classical position, we can also distract it without any other considerations. We could do both of those procedures. Now, we are going to start with distraction because it's sort of part of us, and it's nobody else does this kind of stuff. Not foolish enough to have to work as hard as this. All right? Now, here are the things that I'd like to just point out at the moment. I need her to be vertical to the bed. But I know that this is the correct position. So to get her vertical to the bed, I've got to sort of get close like this and then bring Suzanne, all elements not moving relative to one another, a little bit more like that so I can get above her. So I've set up the position. I'd have to lean way over there to do anything here, so I just hold that position firm, keep my body against her, my arms against her, and just roll like this. And then I can stand up. Now, for the distraction, I'm going to resolve my force from the back with a body contact from the front. And this is quite hard to do. So I've got to get hold of this vertebra here, and a lot of the time this is an impulse technique, but you don't produce the clicks and the cracks that you do with rotation. And I'm going to pull down like that with my body. So you can see my body's doing that, my arm's doing that, both together, they will resolve and pull in the longitudinal direction of the spine. So that would be the movement down there like this. Now on this type of table where we don't have any give in the center of the table to sort of distract, what's probably a good thing to do so that we end up towards the neutral position and not to a fantastic side bend position, because you can imagine that as I'm pulling here, it's more likely to pull a little bit into side flexion to the bed. So I'm going to just take hold of the lower leg and pull it a little bit into left side flexion, just mildly, so that when I pull down, we go more to the equal position on both sides of the joint. So now I come into Suzanne, take up the slack here, and the manipulative thrust will be to come in there and just down like that. That would be the technique, to pull down with my body. And you see I've got a force here, I've got a force here, and one at the back. If I only do at the back, I'm going to flex her. And so we have to have the whole of our positions involved here. Yes?
Because of the setup, are your fingers just palpating, or you're just really...
Yeah, that's a good point. And perhaps I could go back to the point that Barb's just mentioned here. We look at our contact with the patient now, and I'm just going to take her off this position just slightly. We'll leave her more or less as if she's simulating the position here, so she's not under any strain. Okay, I've got, this is what people call the 4 or the 5-point contact. The question is, where does the power come from? The power does not come from your fingers. The power comes from your body and your forearm and all this. And so if the finger contact is getting in the way of where the power comes from, you have to perhaps compromise the technique a bit and use the power things. So for example, if I were rotating, I would say that I've got my arm going back like that and my thumb on the upper side of the spinous process here, taking it down to the bed. The fingers here would be on the lower side of the caudal vertebra, pulling it forward, which would be creating a very local rotation. And then my forearm is coming around here on Suzanne and pushing down there. Now on her, I could do that perfectly well, keep a 4-point contact. But if I was dealing with Chris, I probably couldn't do that because I'd be like this. And I'd have to get up on top of him and come down like this and probably compromise even keeping my finger on this. This one would monitor it, but I would want to sort of come out and do it like that. So rather than sort of be up here, you've got to think power comes from here and through there. And I've got to get my body up and over and do that kind of movement.
For the rotation?
For the rotation. For the distraction, I've got to get round the front, and with this one, generally, you can get your fingers on the back, but the chances of producing clicks are not as high as with the rotation. If I had to compromise, as you will see when we do L5, where I'll be digging in like this, what you do here is you put your arm on the sacrum like this, and then I come down there, and that would be the technique. Using this, not using the fingers at all. But you wouldn't want to jab your elbow higher than that. It's okay at the sacrum, but higher than that, you've got to use your palm and your fingers a little bit to catch hold of these, whatever level you do. But this, this is for the distraction. For the rotation, you will be thumb on top, fingers underneath, and do that movement. But if there is a compromise, take away one hand and use the forearm. Don't try and always keep the 4-point contact, because it won't be totally successful. So, we kind of got a little bit on an additional thing there, and perhaps I should have left it. So here we're going to just do the distraction first of, let's say, 4 on 5, 3 on 4. Set all your forces up, use this distraction here. It would be impossible, I think, to use distraction from above downwards. You'd have to do it in sitting and just lift like this. You certainly can't do that. So the whole of this distractive technique, which is very useful, is gained with the body. So let's try that. Set up the thing to start with the classical position. Go over it with your partner and what you're trying to achieve. Have a look at the side bend rotation and see if it's all local. And then let's do a distraction movement. And you should distract slowly. See that there's no increase in leg pain. Ease off. Then try a little impulse downwards of a distractive release.
body's kind of going this way.
Everything.
And
Yeah.
your line of force is
Is lying down there. So this is pulling down, that's pushing down, and I'm hoping that I'm coming in line with the axial
so your
line
hands
of the body.
your arms like this.
Is that my body's on the side here, the body does that, the arm does that, so both together I do that. Okay? A hard technique, but all of you are actually, don't be disappointed if you don't get clicks. I must say, on the first course that I ever took, which was with Stan Paris on manipulation technique in the sort of 70 or something, you know, none of us got clicks and we were all quite sore at the end of the time. We're just teaching things in a different way. But the lumbar spine, to do distractive stuff, occasionally you'll get clicks, but not all the time. But you're still doing an impulse, and it's still a quick movement. So it still falls within the category of a manipulation. You just know that if you've got a click and it was at the right level, in the right direction, that in actual fact you achieve the full movement that that joint is capable of moving. But of course, when you think what's happening in the disc with, or in the segment with the distraction, what we're getting here is that the disc is doing this, and we're getting a caudal cephalic glide. And as it's the facet maximum opening that causes the click with this cavitation, the chances are doing that is not going to achieve it quite as well as doing this. But that movement on the disc might be more desirable than that movement. That was the old thinking. And perhaps it still should be part of our thinking. Now then, what I'd like you to do now is to take up, so long as there's no contraindications, in Ralph's case here, he's got quite a loose joint at L5S1, so this wouldn't be one to do on him. You could set it up and just sort of make sure you can feel the pressure, but don't put any pressure on. Okay, let's go to the L5S1 now. So it will be identical, except that I will be using hardly any setup from below because it's immediately arrived there. So I just want to make sure that I've got no movement in that. I come up a bit and it moves it, so I know I've actually got the lower lever to there, and I back off a little bit. Now I've got to do slightly more rotation to get through 5. To get through 2-5 from above, so I shall pull. Okay, and I've just about arrived there. Now, when I say I've just about arrived, I can fine-tune it by looking at my position there. I'm going to take hold of Clay and hold him stable, one segment to the other, move him a little bit because I need to climb on top of him and get, you know, above him to do this technique reasonably well. I don't want to move any of these relationships though. Then I can fine-tune to get into 5 now, and I realize that now I've got 5 and I'm putting some distraction on it. I could give a little lift with this leg, all right, and then I can fine-tune to distraction. I'm just going to hold that with my body like that. Then I'm going to take the sacrum here on my upper arm, just above the epicondyle, to there. And my technique now is to be pushed out like that. So that will be the technique there. And you've got more power doing this. It's a pity we can't do that up here, but it's not so comfortable up there. You've really got to do this. But this against the sacrum and the body, and like that. Oh, you do have to work hard for your money, Mr. Lamb. You're absolutely right. But this is worth doing because it's so effective, and we are the only group that does this. So you get your jab in all the time. So we've got everybody talking about manual therapists. Okay, so that's exactly the same technique. The localization's a little different just because we've got to do less from below, a little bit more from above, but just to get that contact there. And as you see, I've got my rib cage in the side, my arm over the top, a little bit of stabilization with this, then straight down with that arm. Let's do that, then we'll have lunch. Gives our backs a bit of a break.
You want to do it on me, please? You need to get up.
Anyway, what's that matter? We're back. And at the correct time, so we will start.
Well, how do you know that everybody's back? I'm here, so start.
Right. Let us talk a little bit about the great technique in this area, which is certainly the rotational maneuver. And this is the one that we were more likely to get clicks with distinct opening of the joint. We've been concerned about this because of the torsion that it places on the disc, and we kind of described a situation where if we actually put torsional strains on the disc, it's actually likely to draw the vertebral bodies closer together. I mean, that's how we always talked about this. And the question that I think we ask ourselves is, how relevant is all that, and was it actually right? Here's a few figures which might be somewhat significant. This is from Cassidy's article, taking a few things from Schultz and from Adams and Hutton on the bottom here, and talking about the movement of the lumbar motion segment with a 10.6 Newton meter motion. And we see that actually the clockwise torsion this is what he's trying to establish, that the flexion and the lateral flexion are fairly high in terms of the movement and the moment that goes on, and that the torsion is fairly small. And when we kind of consider how much torsion had to be done in vitro to actually cause the wreckage of a disc, it was much, much more than is, I mean, many, many degrees more than is actually present in the spine. And then he sort of goes on to talk in terms of the motion that's present. This is from Hutton and Adams, and this illustrates that point I was telling you this morning about when we do flexion extension studies, we see there's more flexion at the L4, L5 than there is at the L5S1, but there's more extension at the L5S1 than there is at the 4-5. And if that reverses itself, and we feel that there is some change in that relationship, we're probably dealing with, given movement in both directions, that there is a problem of hypermobility and possibly instability occurring. The axial rotation, you'll see, is largely controlled by that whole rotational absorption system of the neural arch and the disc, and particularly with the impaction of the facet, which is a very important point. Of course, the impaction creates a focus of motion there, an axis of movement there, and will definitely spring open the facet a little more. But does it protect the disc? This is the real thing, and it probably does. And particularly when we see that as we do this, we're pulling a little bit into flexion and also into distraction, because that's the nature of the rotational movement, certainly above the level of L5. So Cassidy sort of feels that we've overemphasized the rotational elements, and perhaps we should rethink it. And from his studies, it seems to suggest that this is true. Okay, he's got the postulate of the hyperflexion loading, which is the Adams and Hutton principle here of coming down, and perhaps the weight gives us a little more flexion or a little more torsion, and this is a sudden damage. Or we can get the sort of fatigue kind of creep with flexion, which gives us the same consequence but over a slower period of time. So it can be time related or it can be stress related in the same sort of positions. And so he's wanting us to sort of think a little bit about the torsional nature. He's got this diagram here, which you will recognize, which is part of the Bogduk and Tomey group and the Farfan group, of showing that when we get the three joint segment rotating, if it was rotating very forcibly and we had a major torsional stress, these are the consequences. We can get damage within the peripheral fibers of the annulus. We can get avulsion fractures on the side of the facet that stretches, and we can get various forms of facet fractures, such as these subchondral fractures, laminar fractures, and so on. Kirkcaldy Willis used to have a whole lot of slides, which he gave me a set actually, which shows these sort of fractures having been stabilized over a period of time, but giving us a change in the length of the lamina. So what we have now is a fixed rotational set at these joints, you know, which obviously upsets this thing and seem to give us strength in the sense of not doing rotation. But Cassidy has put a further view on this by looking at those, that it doesn't really seem to make matters worse, even when you've got a disc proven by CAT scan. And the lower diagram is sort of stating that there'll be some fibers at some stage in that disc which will absorb this rotational loading. So perhaps he asked us to think again a little bit about this. He feels that the direction of force and the pressure increase is important, and we sort of worry about rotation, but look what flexion does in terms of kilopascal pressure increases, in terms of flexion and lateral flexion, far higher than when we do torsional loading. You know, so this is perhaps significant. We sort of feel, oh, this really increases the pressure by squeezing the bodies together and increasing the pressure. And we look at what flexion does for a given Newton meter moment, and look at the difference in pressures created in flexion and in torsion. And so this might be sort of significant. Okay, so let's just go over the setup now, which we've done, and I can just review so that once again we send blood up to our brains. Actually, I'm having been forced into eating Mexican by Chris, which was quite nice as a matter of fact, but I didn't have all the stuff falling out of it, which drives me crazy. When they fold it all over, it all drops out. Okay, here we've got the side posture positioning that we know, and we're trying to build up stresses from above downwards and from below upwards, so we focus on this point. And the key was that that point is left in its, as best we can, in its neutral position. And then we decide, by taking up the barrier, is it going to be a distraction or a rotation or a side bend or whatever. Our two major techniques, unquestionably, are going to be distraction and rotation. Now, the postulate that, and here we are coming into this position here, and just positioning this so that now we've gone through that passive movement setup. So we get it to here, then we could mobilize and get to the paraphysiological space, and then the paraphysiological space we could just go a little beyond that. Now, what I was suggesting this morning, and it was purely off the top of my head as I was talking, is that, is this paraphysiological space changed in terms of a pathology, or do we always consider that's where the range of movement is, and it corresponds with the anatomical barriers of that joint? Because if we can consider it earlier in the range, then the argument that I brought forward this morning might not be defensible. But if we can sort of talk about that physiological range, we're talking about a pathological range short of the physiological range when we're dealing with a problem. It might get us over this next thing about what to do in states where, you know, they've got that thing at the barrier. They've been a little bit specific in that. It's kind of a bit of a shame that they brought in so many factors, and especially if we did that ourselves. So we try and get to that point, and then we do. And this was the thing with the one with the article from Cassidy, was they mobilize. And this is a feature of all of these manipulations. They mobilize. And they have a look at what the effect of pain is. They talk about the gating mechanism. They talk, as we would do in here, talking. It's just the same as if we were doing this. They talk about the great value of altering the gating, and also of the vascular effect that this has, so long as it doesn't stimulate any of the nociceptors. And so they mobilize this. Check out what's going on. See if they can get through that passive movement area of the joint there until they can get to this, and that's when the manipulation would be done. And as you see, the manipulation for the side posture here, we sort of come into here, and this is where we get the crack, which is at that paraphysiological zone. Now, what's the significance? It simply means that you've moved that particular segment a particular direction, a particular amount, when it was stiff. Have we moved anything? According to this, we haven't moved very much. But just have a look at this before we look at those figures. He's sort of suggesting that you can hook around the spinous process, which would be all, you know, absolutely what we would talk about. So it's kind of strange to me. I think we wouldn't be doing this, because this is a very long lever, and we would try and get our forces here and here. And we'd use our body here and our body there. And that's not done in chiropractic very often. They use quite long leverages, although they say that they are point specific. he suggests on the next one that a manipulation technique has been very effective. And you'll see in volume number 2 that in the last part of it, in the line diagrams from the German school, that there is a diagram of a manipulation technique being done just straight in and just increasing the lordosis. Cyriax used to do a similar thing, except he did it in prone, and he, with his traction, and he did a downward movement, provided that there was no loss of lordosis, so it wasn't done for these kinds of patients, and so long as, when he did his postero-anterior pressures, it didn't cause any peripheralization of pain. But it was his number 2 technique, following rotational techniques to each side. What Cassidy suggests that we don't do, or the chiropractors don't do, would be a thing that you see in Fig 13, which is an ischial contact manipulation which causes flexion and compression and side flexion to the left side of the lumbar spine. And I think that the extension technique that we do that closes down on the facets, we shouldn't be doing in this case either. And so we could follow that and agree with it all. Now then, what are the results of this? We'll have a look at them. They did quite a lot of patients, and you'll see if you look at Kirkcaldy-Willis's article, this was done earlier, the same sort of plan. That these were 14 patients. This is what the advantage, of him working in a hospital is concerned. He can get CAT scans done before and after, regardless of the $400 cost. So CAT scan changes in 14 patients with a lumbar disc prolapse. Those that it didn't change, the CAT scan, 8, but of those 8, 7 were improved by the manipulation. So the CAT scan didn't change, but their physical and symptoms and signs changed for the better. Only 1 didn't. In 5 of them, the prolapse was decreased by up to 50%.